Inflammatory bowel disease, IBD, is a chronic inflammatory disorder of the digestive tract that includes Crohn's disease and ulcerative colitis. People tend to develop IBD during the third decade of life, and therefore, women often have IBD when they become pregnant. If your disease is not well controlled when you become pregnant, or if you develop a flare of your IBD during pregnancy, you are more likely to deliver early or have smaller babies. We hope this video helps you understand the importance of taking your IBD medications throughout pregnancy. Like many women with IBD, you may be worried that taking your IBD medications during pregnancy may harm your baby. Women with IBD often feel that they would rather suffer symptoms of their IBD rather than a medication that they believe might affect their baby's well-being. However, let's take a moment here to understand the importance of staying healthy for your baby. Keeping your IBD symptoms under control is one of the most essential things you can do to improve your chances of having a healthy baby. If you have active IBD during pregnancy, and if you are sick, and not eating well, and perhaps losing blood in your stools, your baby may suffer from lack of nutrition and not grow well. There is also a risk that you may lose your pregnancy because of active, uncontrolled IBD. If mom has active disease during pregnancy, it may increase baby's chances of being born prematurely. Depending on how premature a baby is, this may have serious and long-lasting effects on baby. Therefore, it is very important to continue the medications that you need to keep your IBD in remission during pregnancy. If you have concerns regarding these medications, please speak to your gastroenterologist about your concerns and, please, do not decrease or stop your medications without discussing with him or her. Most IBD medications can be safely taken during pregnancy, except for methotrexate. Taking your IBD medications during pregnancy, even when you are well, makes it less likely that you will have an IBD flare. However, sometimes despite taking your IBD medications, you might develop a flare or worsening of your IBD symptoms. If you think you're developing worsening IBD symptoms, such as abdominal pain, diarrhea, blood in the stool, it is important that you contact your gastroenterologist, or IBD provider, as soon as possible. It is important that you do not wait too long. If the flare becomes too severe, it may become harder to treat, and this could be harmful to the baby. To learn more about specific IBD medications during pregnancy, please select from the following list. 5 aminosalicylates. The aminosalicylate medications include those with the ingredient mesalamine. Brand names include Mazavant, Solofoc, Pentasa, or Osicol. These medications are considered generally safe to continue during pregnancy. If you are on Osicol, it may contain a chemical called dibutyl phthalate, or DBP for short. DBP is used for coating of Osicol. In animal studies, DBP has been linked with some developmental abnormalities. DBP's effects in humans have not been well studied. If you are taking Osicol, you should check with your pharmacist if it contains the DBP coating. If it does, you may want to discuss with your gastroenterologist whether you should switch to another 5-ASA drug that does not have DBP. There are topical forms of these medications, enemas and suppositories, which are safe to continue in pregnancy. Thiopurines. The thiopurines include azathioprine, or Imurin, and 6-mercaptopurine, or porinethol. These drugs weaken the immune system. Early studies in transplant patients who cannot stop these drugs, and more recently in IBD patients during pregnancy, show that these drugs can be continued during pregnancy. These drugs do cross the placenta to the fetus. A small study suggests that it may predispose babies to anemia, which is low red cell count, when they are born. However, if these drugs are required to control the mother's IBD disease activity, they should be continued, and blood counts and liver tests monitored. It would be recommended that the cord blood and infant's blood be checked for blood counts at birth. Methotrexate. Methotrexate should be stopped preconception and during pregnancy. If you were on methotrexate when you became pregnant, you need to see a high-risk obstetrician, maternal fetal medicine, and your gastroenterologist for assessment and counseling. Corticosteroids. Steroids sometimes are needed to control active disease during pregnancy. There have been reports of cleft palate associated with steroid use in the first trimester. However, the risk is low compared to the risk associated with active IBD during pregnancy. Though steroid use may be possibly associated with development of cleft palate, it is important to remember that this risk is only during the first trimester. Also remember that steroids are very effective for controlling IBD symptoms very quickly. Even if you are in the first trimester, your doctor may still recommend the use of steroids, because the small risk of cleft palate is potentially less harmful than active IBD, which can lead to much more serious consequences to the fetus, such as preterm delivery. Biologics. Biologics are engineered antibodies that bind or block chemicals that promote inflammation. These drugs include infliximab, adalimumab, golimumab, ustekinumab, and vedolizumab. The longest safety data available regarding use in pregnancy are from infliximab and adalimumab drugs, which have been used with rheumatology and dermatology before IBD patients. Ustekinumab was used in dermatology patients before IBD patients, and the dermatology studies show it seems to be safe to continue. Vedolizumab is a newer drug that was developed just for IBD patients, and thus there is limited data about its safety during pregnancy. However, if you require a biologic drug because of your IBD, and are responding well to it, you should continue throughout pregnancy in order to keep IBD in remission. These drugs do cross the placenta in the second trimester. However, stopping these biologics as early as second trimester could put mother with IBD at risk to flare during pregnancy. Under most circumstances, we would recommend that you stay on the biologic that is working to control your disease. Your doctor may modify the dosing of the biologic in third trimester to reduce the amount of exposure to the baby close to delivery. It is important to know that biologics can be present in the baby up to 12 months after the birth. Therefore, in the first year of baby's life, live vaccines, such as MMR or rotavirus, should be avoided. Other routine vaccines that are not live can be administered as scheduled. MMR can be given at 12 months. Be sure to let your baby's pediatrician or family doctor know that the baby should avoid live vaccines the first 12 months. It is important to try and begin your pregnancy with your IBD under the best control as possible. If you are pregnant, it is important to partner with your GI and get the facts about the safety of your medications in pregnancy. Remember, our goal is to keep your disease in remission. So, it is important to work with us by continuing with your IBD treatment plan. We know that medications only work if you are taking them.